Dr. Petrossian. I'm the medical director of the Pacific Movement Disorder Center at Pacific Neuroscience Institute, affiliated with Providence St. John's Health Center in Santa Monica, California. Today I'll be talking about new treatments for Parkinson's disease. And in case any of you were at Parkinson's Community Los Angeles's Beyond the Basics program a couple of weeks ago, it will be the same talk. So you're welcome to hop off if you'd like. Obviously, we record these talks and put them on our website for other people to be able to refer to this information in the future, as well as in case any of you want to rewatch it and get information, and we're happy to share the slides as well. If you're not familiar with Parkinson's Community Los Angeles, or PCLA, they do provide a really great service in terms of in-person as well as virtual social events surrounding Parkinson's and really kind of unique, I think, educational talks. So they're a good group to affiliate yourselves with. All right, thank you so much all for being here. So today we're going to be talking about, some good news. What's new? What's out there? What's in the pipeline? In terms of new treatments for Parkinson's. We'll separate that out into symptomatic, meaning how do we treat the symptoms of Parkinson's, versus preventative treatments, meaning how do we slow progression of the disease. So Parkinson's symptoms, specifically, as most of you know, the motor symptoms or movement symptoms of slowness, stiffness, and rest tremor are caused by low dopamine due to loss of dopamine neurons in the brain, and typically are improved with levodopa, which converts into dopamine in the brain. Now, what we're not going to be talking about today is management of non-motor symptoms. And this is very important for people's quality of life. There certainly are quite a few patients where their quality of life is more driven by their non-motor symptoms than their motor symptoms, but that's just beyond the scope of today's talk. So I certainly don't want to imply that it's unimportant, but it's just kind of a topic for a separate time. Non-motor symptoms can include trouble swallowing, constipation, dizziness upon standing caused by orthostatic hypotension, anxiety, depression, and cognitive symptoms, to name a few. So again, those are very important symptoms to treat, but we won't be talking about that today. And everything we talk about in terms of how we manipulate levodopa and dopamine levels, it's not really intended to treat non-motor symptoms. So I've used this diagram in many talks before, and the good news is I continuously need to update this because there's more options in this area. So dopamine is what's reduced in the brain. So we give levodopa, which gets past the blood-brain barrier into the brain, and that converts in the brain to dopamine. Levodopa is also known as L-dopa. People are very familiar with carbidopa-levodopa, also known as Sinemet, but there are other versions of that we will discuss. Then dopamine has to work on dopamine receptors, and then there are separate dopamine agonists that work on the same receptors as dopamine. And we'll talk about some new dopamine agonists as well. The classic kind of older ones are pramipexole, which is Mirapex, ropinirole, which is Requip. Rotigotine, the Nupro patch, has been around for quite a while now. And then apomorphine has some new mechanisms of delivery. Then dopamine gets metabolized into breakdown products. Whoops, didn't mean to do that, excuse me. And so some treatments can work on reducing the breakdown of dopamine or levodopa, and those includes MAOB inhibitors and COMT inhibitors. So rasagiline, selegiline, sufentanimide, and tacopone. And again, there are some newer ones that are not on this slide. So as many of you may know, the concern about why we need new forms of levodopa to treat Parkinson's or different ways of managing motor symptoms are often related to when people are in a more advanced stage of Parkinson's, where their um, dopamine isn't uh, resulting in that same consistent response as it did when they were earlier in the course. So when patients are early in the course, typically they might be able to take 3 doses a day, and each dose improves their symptoms. But as the dose wears off, they have enough basal, meaning like natural levels of dopamine in their brain, so their symptoms remain well controlled. And the specific symptoms, again, to reiterate, that we're talking about are slowness, smallness of movement, stiffness, rest tremor. Those are the cardinal motor signs and symptoms of Parkinson's. So when people have their symptoms under good control with the medication, we call that being on. And then when the medication wears off, if you can imagine somebody who accidentally forgets to take their, second dose of the day, even though the meds are technically working okay, because of that accidental lack of levodopa, they may feel off and then realize, oh, I'm late for my medication, and then take it and it kicks in fairly quickly. A simplistic way of thinking about dyskinesias, which are abnormal involuntary movements, and do not include tremor, is that it represents too much dopamine or too much levodopa. While it's true that dyskinesias are levodopa induced, there are patients who never get dyskinesias. There's patients whose dyskinesias are related to their peak dose, others where it's actually later on in their related to when their levodopa wears off. And there are patients where they get dyskinesias even at the tiniest doses of levodopa. So there are other neurotransmitters and circuitry issues at play as to why people get dyskinesias. But a simplistic way of thinking about it is it represents having too much levodopa. So the left side of the screen represents people who are in an earlier stage of the disease, where by and large they're mostly on over the course of the day, as long as they're taking their medications on time and on an empty stomach and all of that. And then the right half of the screen reflects when patients are in a more advanced stage, where they take their medication, they're feeling off, meaning slow, stiff, stuck, tremor, etc. They take their medication and they don't have a lot of time feeling on because they've gone into a dyskinesia state. And then as the medication wears off, again, they're not spending a lot of time in the on state because they're feeling off. So they're fluctuating between on with dyskinesias and off. And these are also known as motor complications or motor fluctuations, but we'll commonly call that being on and off. It's very important to note that when we talk about off, we don't mean like a bad day, like, oh, I didn't sleep well last night, so I'm off today. Or, I'm just so stressed out and I'm feeling off. Off days are very common, just sort of naturally from either those types of external issues like lack of sleep or stress, but sometimes can happen with absolutely no rhyme or reason. That's not really what we're talking about. We're talking about when the medication isn't working, per se. And that can be hard to tell, to be honest. So there are many new motor medications for Parkinson's disease that did get FDA approved in the last decade or so. Starting that we will discuss Rytary, Duopa. We will discuss Inbrija, and as well as Crexont, Vyalev, and Onapgo, the more recent ones. So longer acting oral forms of levodopa started with Rytary in 2014, which is an extended release version. Again, it's the same old carbidopa levodopa. It is not new in that sense. It's just it's a different formulation. And for many patients, it lasts longer than the older immediate release carbidopa levodopa. Now, it does take a lot of time to say immediate release carbidopa levodopa. That's a lot of syllables. So you might hear me either in today's talk or at appointments refer to it as Sinemet, Sinemet, which is the old brand name. Most people are not on a brand name anymore. They're on generic, but it's just faster to say. It's just got 3 syllables instead of, I guess that must be 12 with immediate release. So Comparing to Cinemet, Rytary lasts longer. And what we're looking at here is the dotted line is the immediate release. So it kind of peaks within an hour and then fairly quickly is wearing off according to the blood levels of levodopa. Um, Whereas the what happens with the Rytary, it's a combination of two components with different timed release. One is this delayed onset here that peaks at 6 hours, and the other one kicks in within an hour or two. And so they combine those two together. And I'm sorry, I misspoke. The extended release is this lower level here. So they combine those two to result in this sort of combined kind of later onset peak. Um, what's neat about Raitari is that it can be opened and sprinkled onto applesauce because there are microbeads within each capsule. It's very important when patients are getting started on levodopa to know that Raitari is not dose equivalent with Cinemet. It does require a conversion, and sometimes it takes a few days to figure out what that right dose is for each individual patient because it takes 3 to 4 days to get to steady state on Raitari. Also, in my experience, I found a lot of people who struggle with side effects of immediate release Cinemet, like nausea or feeling out of it. They tend to tolerate Rytari better because it's sort of a smoother kind of medication. That's just been, my very consistent experience with it. And then in the last year, we got a new medication from the same company that made Rytari, which is called Crexont. Crexont provides an additional 1.5 hour, 1.6 hours of on time compared to immediate release carbidopa levodopa. And in this graph here, you can see Crexont in green, Rytari in purple, and immediate release Cinemet in gray, showing that Crexont sort of has a larger peak and lasts longer than both Rytari and Cinemet. I think that in my experience, I haven't seen a huge difference clinically from Rytari to Crexont, but from Cinemet to Crexont, there is a significant improvement. So this can work really well to improve on time. But again, it generally takes a couple of weeks to figure out what the right dose is because this also is not dose equivalent. Crexont's difference with Rytari is that it has an external layer of immediate release, an internal layer of controlled release, and then a core of a gel core, which adheres to the small intestine and presumably allows for a longer release of the medication into the gut and then into the bloodstream. So for a lot of patients, they experience unpredictable off time where their medication usually works, but sometimes doesn't, either because they, made a mistake and ate a little too close to their dose or for no reason whatsoever. And we think that these unpredictable off times occur because of changes in the microbiome or changes in the ability of the brain to convert levodopa to dopamine. It's not always clear why people have these unpredictable off times, but it can happen where the dose, was usually lasting, 4 hours, but now today it just lasted 3 hours. Or usually it takes about 45 minutes for their medication to kick in, but now an hour and a half has gone by and it hasn't kicked in yet. Or some doses where it just feels like it never kicked in. And so that's where Inbrija comes in. It's really only a rescue drug or a bridge drug to get somebody from feeling off to when their next oral dose is going to kick in. It's not meant to be used on its own, meaning like without other medications over the course of the day. It does take about 5 to 15 minutes to kick in, which is typically a lot faster than their oral drugs. But it isn't very long lasting. It'll only last an hour to 4 hours. And so again, it's really just a bridge where, for example, let's say somebody took their med at 8, their next dose is at noon, they wore off at 11, they are not supposed to take their oral drug until noon, and then it's not going to kick in for an hour. So they have 2 hours of off time they're looking at there. And they can use the Inbrija to bridge that gap. Levodopa gets inhaled into the lungs. And so it's a direct uh, absorption into the bloodstream, and it bypasses the gut, which is really huge because a lot of people struggle with, if they're taking medications 4 or 5 times a day, it's very hard to actually be on an empty stomach. And also, we need people to be able to eat. We don't want people losing weight because they're afraid to eat. So we really like having this medication that bypasses the gut, and has that flexibility of being able to be used only as needed. Because it's only levodopa, it does not have carbidopa in it. People still need to be on that oral regimen. So when I said you can't take it on its own, I mean like people need to have their oral regimen, let's say, 3 or 4 times a day or more of their oral carbidopa levodopa, whether that's immediate release or Rytari or Crexont or what have you. And then the Inbrija can be taken at any time of day. It doesn't have to be taken at the same time as the oral dose. It just has to be that their oral medication is kind of within their system. Some of my patients will use it in the morning when they first wake up to combat that morning off time. It doesn't prevent off time, obviously, because it's just a bridge. So if I have somebody who's consistently having off time, then I should be adjusting their oral regimen rather than using the Inbrija. But again, this is for that unpredictable off time where they're usually okay, but once or twice they might feel off. No, the clinical guidelines are that patients use 2 capsules. They get placed into the inhaler, and breathe in, and that they can use it up to 5 times a day. In my personal experience, I think if you're needing it 5 times a day, that means that your oral regimen needs to be adjusted. In the clinical trial, on average, people were using it twice a day. And I have patients who'll use it once or twice a week, or some people who are using it once or twice a day. Of course, because it's inhaled as a powder, people can have a cough when they first start using it. And I really emphasize, work through it, watch the videos on how to use it, go slowly, and eventually that they get used to how to do it correctly. And the two major hints are drinking water before and after, and taking a really slow breath, because people tend to like suck the powder in very quickly, and that tends to trigger a lot of coughing. So I tend to recommend really slow breaths. You can space it out if you need to into 3 or 4 breaths per capsule, because there's only the same amount of medication within each capsule. Um, and also, I actually do have some patients who use 1 capsule instead of 2. And sometimes it works for them. The FDA approved dose is 2. So that's sort of off-label to kind of only try 1 capsule and see if that works for you. But it's always reasonable to consider that. Okay, so now we move on to longer acting, like super long lasting levodopa that gets infused. And the first time we got this, it was back in 2015. It's still on the market. It's called Duopa. It's an intestinal gel. It reduces off time compared to oral levodopa by about 2 hours. And it's administered via cartridge into, what essentially is a feeding tube, but isn't used as a feeding tube. It's used only as a delivery mechanism for the levodopa. This bypasses the stomach, but still you're relying on the intestine to absorb the levodopa. The initial side effects, such as tube malfunction, slowing of the gut function, pulling the tube out or the tube falling out, neuropathy, typically wear off. And usually, once people are through those first few weeks, they're okay. But it does require the tube as well as the pump, as shown in this diagram. So then let me see if this works. Yes. So next came Vyalev. That came last year. It is basically carbidopa levodopa, but the FOS there refers to that they're what's called prodrugs, meaning they're the precursor to those 2 drugs. So they get converted into carbidopa and levodopa. And that just has to do with the delivery mechanism and allowing it to be infused. Now, Vyalev is also a pump, but instead of it going into the intestine, it goes into the skin, and it doesn't require a procedure to implant. The patients get trained on connecting themselves at home by a nurse. And then they do it on their own after they've been trained. This also showed improved on time and reduced off time of about 2 hours compared to oral carbidopa-levodopa. There were some infusion site reactions or infections. Um, Hallucinations, of course, can occur with carbidopa-levodopa in any form. And the discontinuation rate was about a fifth, mostly in the first 10 weeks. So 80% of people, felt like it was helpful to them. It's important to note that when you switch over to this 24-hour infusion, all of the oral drugs, excuse me, all of the oral carbidopa-levodopa is stopped. And also any entacapone if people are taking a COMT inhibitor. Um, People have been asking me about a different formulation of carbidopa-levodopa that was written about in a proof of concept publication from Australia. It was published in like drug delivery, drug development and delivery. So it was a sort of a pharmaceutical journal talking about the concept of how this was going to work. It has to next go into human trials. Obviously, that'll take some time. But the way it worked in vitro and in pig muscle was that it was sort of like implanted and then released carbidopa levodopa slowly over 7 days. So this concept of instead of having like an external pump that stays on you, something gets injected for 7 days each week, and then it lasts for 7 days. So that's the um, you know thing that will someday be in a clinical pipeline, I'm sure. So the other infusion is not technically carbidopa-levodopa. This got FDA approved just earlier this year, but it also improves on time and reduces off time by about 2 hours compared to placebo. Um, and again, bear in mind that we talk about compared to placebo, right? And it's fair to say that placebo effect is pretty big. So most people who get started on this treatment have more of an improvement in their on time. That's true of all of these that I'm talking about because I'm just showing you the numbers compared to placebo. But well, people feel more of an improvement than just 2 hours, if that makes sense. Um, uh, so. The difference here is that instead of it being a different formulation of levodopa, it's a different formulation of a dopamine agonist that reduces off time. Apomorphine has nothing to do with morphine, so it's not an opiate. Again, it's a dopamine agonist, meaning it works on dopamine receptors in a different way than levodopa. Patients were able to reduce levodopa by on average 15%. And about a third of patients were able to stop at least one Parkinson's med. But you don't go into this infusion expecting to make significant drops in the amount of levodopa that you're taking. The other kind of difference is the ONAPGO will typically be infused over their waking days, whereas Vyalev is typically infused over 24 hours with adjustments in doses, by the way. I should say both ONAPGO and Vyalev, the patients are given a window of how much they can go up on their rate and how often they can give themselves a little bolus dose. Um, and Again, similar to the Vyalev, there is a risk of infusion site nodules or reactions, nausea, sleepiness, dyskinesias, and headache. And about 11% of patients discontinued due to side effects. Um, Moving on, there is a dopamine agonist in the pipeline that is likely to, that has been submitted to the FDA, so still waiting to hear back from the FDA on this. So did go through phase 3 trials very successfully for two populations within Parkinson's. One is people who are not on levodopa and they just want to have motor improvement without starting levodopa. And the other is people who are on levodopa and have off time, which we call, again, motor fluctuations, and want to improve the efficacy of their levodopa or to sort of smooth out their off times. So tavapadon is a partial D1, D5 agonist compared to traditional dopamine agonists that are D2, D3 agonists. And these numbers refer to the specific dopamine receptor. So the D1, D5 is more specific for motor improvement than the traditional dopamine agonist. And the traditional dopamine agonists, especially pramipexole, but certainly also ropinirole, and to a lesser extent rotigotine, can cause what are called impulse control disorders, and somnolence, as well as other side effects like hallucinations. And especially impulse control disorders are very problematic with that class of drug, especially in younger people, where people can have compulsive gambling, compulsive shopping, compulsive eating, compulsive sexual misbehaviors, etc. So the concept is that we want sort of the good things out of a dopamine agonist without the bad stuff. And they were able to show that this medication did do that in these two major phase 3 trials, separate trials because they were separate populations they were looking at. It was once a day dosing, and it does seem that in early Parkinson's, it would be able to delay starting levodopa because it improves the motor score by 4 to 5 points. There were mild side effects of nausea, headache, and dizziness that typically would go away. And in moderate Parkinson's, where people are having off time, it improves off time by about an hour, again, compared to placebo. Um, Moving on. Okay, so moving away from medications to um, surgical and advanced treatments for off time, as well as other symptoms. Adaptive DBS got FDA approved just this year. So you may be familiar with DBS. It's been around since 1997 for Parkinson's. So not a new treatment in that sense. In the fact that it's a pacemaker for the brain, it allows the efficacy of the medication to last longer during the day. It treats the motor symptoms of Parkinson's like tremor, off time, and dyskinesias. It requires the implantation of electrodes, one on each side, a wire underneath the skin, and then a neurostimulator under the collarbone, under the skin. So nothing is sticking out. It's called stimulation, um, uh, but there's no like electrical feeling that the patient has. And for selected patients, it's going to be very effective for these symptoms. What's new in terms of adaptive is the concept of having information from the brain and then giving the stimulation only in response to that information. So on the left where it says A is what traditional, also called continuous, also called conventional DBS was like, and or is like, I should say, because most people are still on this form of DBS where they have an evaluation by myself or a nurse practitioner or a neurologist, et cetera, which we then clinically observe changes to those symptoms as we manually adjust the stimulation parameters. So really just one source of information. How are you doing? How do you look? Adjusting the stimulation up or down depending on that. Whereas on the right, what we have is what's called Brain Sense, is the brand name from Medtronic. The brain sense signals to the sensor in the DBS, in the implanted pulse generator. And then within that same unit is a processing unit, a programmer, and then adaptive adjustment of the stimulation to tweak the stimulation based off of those what is that information. Let me just move this over. Now, please disregard where it says turning on off the stimulation because that's really not what we're doing with adaptive DBS. We're just adjusting it up, down slightly. Another analogy I like to give is if we think about a person, a child on a swing, if we were to push the swing constantly, push forward and then push, 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 push as they're coming back. Push forward, push back. That's very inefficient and causes, wonkiness. So what we're doing with adaptive DBS is we're only pushing when the child is at the top of the swing, right? So the concept is only stimulating when the abnormal signals are coming from the brain itself. Well, again, adjusting up and down. I don't mean on and off. So the concept here is um, the uh, the symptom control goes up and down with the medications, and then DBS. This is the blue line. The DBS is on at the same level the whole time. Whereas this yellow line is the what's called the beta band. It refers to a specific brain signal in a range of frequency called the beta range. And LFP stands for local field potential. So this is the power of the signal from the brain correlating with symptoms of akinesia and rigidity up and down over the day, but the DBS is on the whole time. Now and so this is Percept. The one on the left is the non-rechargeable. The one on the right is rechargeable. I apologize. I should have fixed this. This is actually much smaller than the PC. I'm sorry that this ends up looking like it's the same size. It's roughly the size of an Oreo, literally. Maybe a bit bigger than an Oreo, both in, diameter and width. That's how big these batteries are now, which is to say they're much smaller than they ever used to be, which is really cool. But what we're seeing on the screen here is what we see when we're doing adaptive DBS programming which is we can measure that beta band, the abnormal signal, and then correlate that to stimulating more or less depending on if that signal is coming through. And the concept is that we're seeing, better control of symptoms with fewer side effects is what the trials showed. So moving on to focused ultrasound, that got FDA approved for tremor predominant Parkinson's in 2018. Then for unilateral motor symptoms of bradykinesia, rigidity, and dyskinesias, it got FDA approved in 2021. And then just in 2025, bilateral motor symptom improvement. And I may need to update this slide as well, because what's interesting is when we talk about what symptoms are we managing, it's based off of what brain target are we talking about. And you may have heard us talk about focused ultrasound in the past. It refers to, let me show you up in here on this corner. It's an MRI guided ablation, meaning creating a lesion using 1,000 beams of ultrasound. And the analogy I like to give is if you take a magnifying glass, you can focus the rays of the sun and burn a hole on a piece of paper. And here we're using 1,000 beams of ultrasound and burning a hole in the brain. But what's changed in terms of these different FDA approvals is where the targets are and whether it was unilateral or bilateral. So the old, the tremor predominant was only one target in the brain that only treated tremor, whereas the 2021 and 2025 targets are different targets in the brain. The globus pallidus, meaning GPI, and then more recently the pallidothalamic tract, PTT. So improvements of about 50% in the half of the body that was treated at 4 months without medication. For the bilateral treatment, this is a different way of thinking about it. They're talking about how many people responded to the treatment. It was 70% of people responded versus 32% of people who got the sham treatment. Side effects typically improve by 4 or 12 months, but can include speech disturbance, gait disturbance, dyskinesia, and weakness. Again, focused ultrasound, we consider it brain surgery, but it is not with no incisions, no hardware, and effects are immediate. So it's a really promising treatment, especially for people who are not keen on having an invasive brain procedure. But I like to call this a non-incisional approach instead of, I wouldn't use the word non-invasive, but I would say it's less invasive. And we do have focused ultrasound now at our sister organization, little company of Mary in Torrance. So we're excited about this technology. I like to show people these types of graphs because what we're looking at is the nuance in terms of the range of response to the treatment. So in the blue are active treatment, in the red sham treatment, meaning a fake procedure. They thought they were getting the procedure, but they were not. And they did not know that. So the improvement is going to be, oops, sorry. Improvement will be on this y-axis, and each bar on the x-axis is an individual patient. And so you can see if we sort of draw the line around like maybe say 40%, actually no, even at 50%. If you look at 50% improvement, a little more than the majority are above that line. But there are people who had more like a 30% improvement. Some people who didn't improve very much at all. Compare that to the sham procedure where, most people had at best about a quarter, a 25% improvement. And then some people, didn't improve at all. So it gives you a sense of some people had this fantastic improvement above 75%, but that's kind of a handful. And of course, this is a small trial, but it's similar with larger trials is that there's this range of improvements. So moving on away from symptomatic treatment to preventative treatment. I have to mention the best evidence for preventative treatment, how do we slow progression of the disease, is exercise. And everybody already knows that. But what's cool is that there's different types of exercise that maybe you've not thought about. I think the most recent new one that I've heard about is the rock climbing, like upending PD. I think most of you have heard about ping pong for good, rock steady boxing, dancing through Parkinson's, anything and everything, right? Like I tend not to say no to most things as long as it's safe and of course that people are not putting themselves at risk of injury. And in fact, important that it's fun too. There's also good evidence for the Mediterranean diet, stress and mood management, sleep quality and quantity, cognitive stimulation, social engagement, cultivating joy. All of these things are super important. Slightly less evidence, but just sort of, clinically we see the differences. I also want to kind of hit this other point, which is that you'll probably get emailed by your, third cousin's next door neighbor's roommate of, oh my God, I just read something that they're going to cure Parkinson's. And I know it kind of can get frustrating. They feel like, hey, I heard this, and yet nothing seems to be coming to the clinic. And it's because a lot of these things are really in the basic science stage. And, there is a risk of doing harm. And we, obviously we take the Hippocratic Oath, first do no harm, number one. And number two, like we don't want to be encouraging people to take things that aren't going to work because, then we're, no better than selling snake oil, right? So we really do need to take things from basic science to the clinical to have that understanding. And just to be a little bit negative today, in a talk that's mostly uplifting and positive, I think one of the frustrating things is that there isn't just one cause of Parkinson's. It isn't as simple as, oh, one of the headlines, they're trying to sell newspapers. I guess that's an old-fashioned way of saying they're trying to get clicks. But the headline will say something like, Parkinson's is caused by this one bacterial infection, implying that if you treat this bacterial infection, you're going to get rid of all the Parkinson's. Well, that bacterial infection may be associated with a slightly higher risk of developing Parkinson's, but it doesn't mean that A, everybody with that infection gets Parkinson's, or B, everybody with Parkinson's has had that infection, meaning that that infection is neither necessary nor specific for developing Parkinson's. And also, unfortunately, even if something was kind of contributing to the disease, treating it or getting rid of that issue doesn't often doesn't make the Parkinson's go away because Parkinson's is very complicated in its development, very multifactorial. So bear with me as I try to express some of this quickly. So antibodies against alpha-synuclein is, one of the main kind of understood causes of Parkinson's, where there are abnormal forms that misfold, and then those misfolded singular alpha-synuclein proteins clump together and gum up the works, creating an inclusion in the cell and then causing that cell to die. So antibodies against alpha-synuclein are, thought to be very promising. Unfortunately, there have been a couple of failures in some of these antibodies, but there is one antibody against alpha-synuclein that that did decide to go on to phase 3 trials. In the phase 1 and 2 trials, good target acquisition means they did clear out the alpha-synuclein in the spinal fluid, and the safety was fine, but it didn't show efficacy in the primary outcome measures. Whereas if we look at, and so that's this thing on the right here, this top line where the blue is they didn't get the, I'm going to say this correctly. The shaded line of yellow is they got prasinezumab, whereas the blue line is for a full year, they only got placebo. And then in the second half, they received here in this dotted line, they got put on the prasinezumab. So you can see that these lines of progression aren't really any different. So the primary outcome measure was considered a failure. But what was that primary outcome measure? It was parts 1, 2, and 3 of the UPD, the Unified Parkinson's Disease Rating Scale, which is to say that, it's a slowly progressive condition, and people, are generally, staying healthy, staying active. Whereas if you look at the part 3, which is, I think, a little bit easier to see change, that's the motor score, which is here in this bottom column. Oops, sorry. Sorry, I just turned off my screen. Hopefully everything seemed normal for you. Where what we can see is that there was an improvement in this underneath orange line. So the slower the progression, the better. Sorry. Why was it so successful in the preclinical trials, meaning in animal models, when we know that it reduces aggregation of alpha-synuclein, it limits neurodegenerative, and it improved motor function. Why didn't it work as well in humans? So, unfortunately, we think that part of the problem may be that we don't have a prospective biomarker. We're just looking at how people look. And as you guys probably know, you might have a good day, you might have a bad day, you might not have yet eaten well, what have you. There's so many factors that go into like what the clinical picture is. These are clinical outcomes. Whereas, I think the concept of what's happening in the brain, what are your dopamine levels? How many dopamine neurons are left? That would be a biomarker that would probably be more useful, but we don't have what's called a prospective biomarker. So we don't have something that we can follow. Like the analogy I always like to give is like PSA, it's a blood test. It's not perfect, but it can be a useful biomarker for prostate cancer and treatment for prostate cancer. It's a blood test, it's non-invasive, it's cheap, it's easily repeatable, and by repeating it, you have more information than just having a single level in time. And we don't really have that for these trials. The other issue could be disease mechanism. So it's quite possible that the alpha-synuclein isn't the whole story when we're talking about the disease. And then it may also be a matter of timing of the treatment. There are ongoing studies in antibodies and vaccines. Some companies are choosing to start looking at patients with multiple system atrophy, which is a more complicated and rapidly progressive condition. And then there's a vaccine called, now it went from phase 1 to phase 2, and they sort of changed their name to ACI 7104. That just rolls off the tongue. It's a vaccine against alpha-synuclein clumps. and it was found to be safe and tolerable and to work, meaning that it caused the body to create 20 times the antibodies compared to placebo. So the concept would be that the body would fight off the the development of the alpha-synuclein clumps. There is also another company called Vaccinity that is entering into this with a phase one. People ask me about stem cells all the time. So, stem cell story has been around for a couple of, a couple decades now. But the most recent breakthrough, very exciting, is that instead of implanting or infusing stem cells, they're actually implanting dopamine neurons. So the analogy I always like to give is a stem cell is like a newborn baby. A newborn baby could grow up to become anything in this world. It could be a politician, it could be a rock star, it could be a plumber. But at its core as a newborn baby, even though it's, pluripotent or it isn't any of those three things. It's just a newborn baby. And you don't need, newborn babies. You need a rock star, right? So what now is being done is that in the lab, they're taking newborn babies, giving those factors that are necessary to develop into the proper type of cell, creating rock stars, meaning dopamine neurons, and then directly implanting those dopamine neurons into the brain. And why are they doing that as opposed to, I'm sure a lot of you have heard about stem cell treatments that are not FDA approved, in this country, outside of this country. They tend to get infused into the blood or through the spinal fluid or whatever, or in through the nose. I've heard of it all. Why are they implanting it directly into the brain? It's because that's where the dopamine cells are missing. So it's much more specific to the exact cell that's needed, exactly where it needs to go. So it's much more, I think, exciting in terms of actually creating what we're looking for, which is a replacement of dopamine cells. The one that people may have heard about came from Blue Rock, which is now also being managed by Bayer, the same people that make aspirin. It was a phase one success in advanced Parkinson's, which improved the motor score 23 points in the high dose cohort and improved dopamine levels on a PET scan. The phase three trial is pending. Because these are looking at other stem cells that then get created into dopamine neurons, it requires a year of immunosuppressant therapy, whereas the Aspen trial is looking at cells that are autologous, meaning they'll take the patient's own stem cells, like typically from fat, and then create neurons from there, and not need the immunosuppressant therapy. There's a phase 1/2A trial ongoing. The data from the first three patients did show a 45% improvement in the UPDRS part 3. Lund University is also doing a stem cell trial, again in phase 1/2A. Now, these trials are going to take a long time because we need to assess safety. They need to project to the correct brain regions. They'll typically take at least 6 months before any difference is noted. We have to make sure that the grafts, meaning the cells that were implanted, that they survive and that the benefits are durable. So do not expect these to have quick turnaround. We're not going to have answers on dopamine cell replacement therapy options for a few years. So, and the trials are looking for people who are in really kind of this unicorn stage of being moderately advanced where they're having off time, but they're not doing too poorly. Okay, moving on. So I've given another talk about genetics. You can find that on our same website. But just an update on that. GBA and LRRK2 mutations are the most common genetic risk factor genes for Parkinson's disease. And there are some trials that are, I like to say, inspired by that, because we're still not sure if this is going to then imply that we're going to personalize medicine where only the patients who have these mutations are going to benefit, or if they actually might benefit all people with Parkinson's, because the GBA codes for something called glucocerebrosidase, which is a enzyme that folds removes alpha-synuclein naturally. So when people's GCase enzyme isn't working, they can have this enhancer, which is called ambroxol, that may sort of do the work for them. The ambroxol is a European anti-mucus medication that's like over the counter, but the dose is crazy high. It's 2,100 milligrams, which is, probably about, um, you know, 100 times kind of a typical dose that they'd use for a cold. So it isn't really available in the United States, and they're doing a phase 3 trial to see if it actually works. But they are including people with and without the GBA mutation. Um, Bial has an ongoing phase 2 trial where we're expecting the top line data next year of a GCase activator. Unfortunately, there was a different GBA mutation related treatment that did fail in phase 2. And then LRRK2 mutations cause an increase in kinase activity. So to inhibit that, that also is important in the clearing out of abnormal alpha-synuclein. And there's phase 2 trials ongoing for that one. So in conclusion, there have already been a lot of advances in motor symptom management, both medication and non-medication approaches. We have cautious optimism for preventative treatment and dopamine cell replacement therapy. And, if you guys are interested, the only way that we'll have better treatments for Parkinson's is patients with Parkinson's participating in clinical trials. So clinicaltrials.gov and the Michael J. Fox Trial Finder are good tools if people are interested. Obviously, clinical trials have really strict inclusion-exclusion criteria, so not everybody will be a candidate for every trial, obviously, but if you're interested, that's where to look. Clinicaltrials.gov. If you guys have questions, ask your treating physicians and teams. I think it's really, a great time in terms of, better treatments that are coming down and have come down already. So it's exciting times. Nothing is perfect. I'm not trying to imply that anything's perfect, but I think it's a good time now. So thank you all for joining.